Very good afternoon, everyone, and a very warm welcome to you all. I am Dr. M. Shreya Jaiswal, and on behalf of Dibridge, I wish you all a very happy dentist today. And it is my pleasure to welcome you to the webinar on hands-on live training on E-Wireligner. So those who are new and those who don't know about E-Wireligner, so it's an innovative orthodontic NiTi Memory wire with a patented food-grade coating, which eliminates the need for traditional brackets. So today's session has been carefully designed to provide you with the scientific insights, anterior teeth alignment case, biomechanics, and hands-on E-wire demo and case discussion followed by Q&A. So we are truly honored to have with us Professor Yeon Suk Chin from South Korea. So Professor Chun is a professor at Ewha Women's University and CEO of E-Wireligner Co. Limited. So he is a highly respected academic clinician and researcher in the field of orthodontics. He completed his PhD from Yonsei University and served as a professor at Ewha Women's University, South Korea for over 35 years. He has also served as a visiting professor at the University of California, San Francisco, and he has also authored and co-authored more than 78 peer-reviewed articles and textbook chapters. So meet our panelist, Dr. Gurkirat Singh. He is a highly respected orthodontist from India, and he completed his BDS and MDS in orthodontics from Manipal University, India, and holds diploma from Royal College of Surgeons of England and Royal College of Physicians and Surgeons at Glasgow. Along with our esteemed speaker and panelist, we have Ms. Lena An, founder and CEO of Dbridge. So after studying dentistry from the University of Leeds in UK and chemistry with management from the University of Edinburgh, she has spent for about 15 years in healthcare industry, specializing in marketing, business development, and sales, which has allowed her to build direct relationships with over 5,000 clinics worldwide. So before we begin this session, a quick note for all participants that if you have any questions or any queries, you can put your questions in chat box or Q&A box, and we will address them during the Q&A segment at the end of the session. Without further delay, let's get started. Over to you, Professor Chun. You may start your presentation now.
Good afternoon. My name is Yoon Chun. Just to introduce. So today's topic is E-wire and anterior alignment. And for many years ago, I practiced anterior teeth alignment. So the first step is how to place the E-wire in the clinic. There is an etching procedure, and remove the etching solution and dry, and coating a bonding agent. There is base. After that, dry again the bonding agent, the curing, the UV lamp. This is a 0.08-inch E-wire. Open the envelope and the E-wire. The wire's color is white because of the coated material. Let me introduce and explain the detail, the step by step. The first step is cleaning the tooth surface. This is very important because that the resin bonding is a very critical point during the treatment. If the wire is falling down from the tooth surface, the patient complain. Stop. Okay, this is etching solution. Etching solution first, and normally 20 seconds etching time is 20 seconds is enough. And then suction the solution and wash out dry and bonding the bonding agent and air dry again and curing. That is a very important procedure. The next step is E-wire. Open the E-wire like this from the envelope. 008-inch E-wire as pickup. And you can see that the wire is white colored. That is coating material was coated by the PGA. Is that this time is the wire is a white color, but after wash out the wire is changed to original wire colors. And place the wire.
So the white coating layer is water soluble layer.
Yeah, water soluble. Yeah. Look at this video was made 3 years ago. So nowadays we place the P-clip in the posterior part or posterior tube before inserting the E-wire in the posterior teeth. And at that time, we only changed the anterior part. So because of that, we didn't use the posterior attachment. In this case, how to place the wire in the stabilizing the anterior part. The first step is a normal region is placed at it's a normal anterior teeth, and then the E-wire placed at the region and the curing. That is stabilizing the E-wire in the anterior part. And then curing, and the other part is also curing. So same procedure was done. So the canine to canine, the E-wire is placed. At this time, we didn't wash out the E-wire, but you can see that wire is changed from white to the wire color, so 약간 reddish, dark colors, but not cleaned, not washed out yet, the coating material. So curing and the distal end, the canine distal, and both canine distal area was cut up the wire and wash out and dry and clean the posterior canine distal end smoothly. Yeah, smoothly. that is smoothly by. Uh, okay. This is a lower E-wire, coded wire. So you can easily apply this wire in the minor crowding case. But nowadays, at first we only used anterior segment, canine to canine, but canine distal area is sharp and sometimes irritate the patient mucosa, oral mucosa. So nowadays we recommend the wire extend to the premolar, first molar, first premolar, second premolar. That is upon your decision. So the minor crowding is affect the 0.08 inch, but sometimes the crowding is more severe and moderate. You can initial wire choose that 0.10 or 0.112. I recommend, strongly recommend, not 0.08 inch in the first wire. And next is upper, how to place that the upper wire. The lingual approach. Yeah. Let me explain this indirect bonding techniques. This appliance was made by the laboratory, orthodontic lab. The blue color region is a guider, the precise place that the guider. The white color is a region, real attachment. So the wire is connect from the white region from to canine area. So the purpose of this appliance is that the precise positioning of this attachment, the rear side. Before making this appliance, we have to set up the model in the right line. Yeah. So we applied this at the intraoral. Yeah. Okay. You can find that this like this. This is a setup model. Setup model. This appliance is placed at the setup model. Etching and bonding is the same procedure. So, okay. It's very important procedure for lingual approach. The first place that the attachment is a canine, and the other side canine, and the second bonding. Yeah. Okay. And the remain attachment is step by step, one by one, the place that the bonding and adhesive agent. Okay. As finishing and detailing and cutting the distal end extended wire and remove the guider. Yeah. Okay. This wire is also made in laboratory, the coating wire. The coating wire lab technicians wash out the coating E-wire during the making the jig. They use that the E-wire. After finishing the jig and the attachment, they remove the coating material washout. So and they deliver to the lab, the clinics. Yeah, but lab fee is over in Korea, $200 per each arch. Yeah. So this time I introduced the lower E-wire directly application procedure, and the second is upper indirect appliance, indirect bonding technique when using the jig appliance. The wire is only very cheap than the jig appliance. But sometimes if you want the precise bonding the E-wire, labial or lingual, you can use that jig appliance. But if we want to do that, we can recommend one of them, direct or indirect. Any other question?
So far, if you have any question, you can ask, or you can put your questions in Q&A box or chat box. Professor, there is no question, so you can move ahead.
Today's topic is anterior space control strategy by simple approach. This is very simple. The upper right central incisor was impacted. The patient age is 7 or 8 years. So like this. So in that case, we have to make the flap and close and the traction. That is a flap close eruption technique. It's very simple, and finally we get the final result. That is very important because that the flap closed eruption is to maintain the gingival condition and the gingival height. So it's very nice. So, but sometimes the impacted teeth, we open the gingival tissue like this. So window open procedure is very inefficient. It's easy to bracket by bonding the bracket and the traction like this, but you can find that the different gingival level. So loss of attachment than the normalized. So if you met the impacted teeth upper incisor, you choose that open procedure, window or flap closed eruption technique. So flap closed eruption technique is very prominent, the beneficial approach. So this is also open procedure. Uh, so you can find the different gingival level attached to gingival level. So finally, we get the for incisor, but still the attached to gingival level is different than the other side. Window open procedure is not good, recommendable procedure. Flap closed eruption is better than the window open procedure. So this is also impacted teeth. This teeth is impacted the other side. So we place the orthodontic screw placed here and the connecting wire and the light curing the edges of the teeth. That is an indirect skeletal anchorage. We called it, I made it. Yeah. So you can find like this, like this, like this. So this is a window open procedure. It's not recommended. Anyway, this is like this. But how to control the root movement? We use the indirect skeletal anchorage and rigid anchor and step by step, and you can find like this. So after that, we're like this. Finally, this is a bonded power arm and attached like this. It's very useful for root movement. Yeah. So let me introduce that. So it's very final. Yeah, you can find it. Okay. 10 years later, the patient has got optimal results. Next, how to manage the prolonged retention of ankylosed deciduous molars. This is a deciduous molars. So, like this, ankylosed premolar, deciduous molar. Look at here. So, you can find the defect area, how to control this area. So extraction, when, and then how. You can find the third molars on this side. So we remove that prolonged retention of deciduous molar. So after that, gaining the space for place that the third molar's transplantation. The space was gained and place the third molars like this. This is good, but this side is a little bit not good. But upper side is a third molar also. We can transplant it, but not correct. Anyway, this side is a nice reposition, but this side is not so good at the other side. So success, fail. This is a still ankylosed. This is a malpositioned. You can find the occlusal view. The hospital pacing is stopped. Yeah. Anyway, if you met this ankylosed deciduous molars in the like that, the bone level is under. So if you extract this side, is a hemiseptal bone defect was developed. So we transplanted from impacted third molar to this side. This is a successful. This is a little bit not so good, but the alveolar bone level is good. So this is yeah. After transplanting, the bone level is successful. Yeah. Before and after, step by step. Yeah. So pretty good. Yeah. So, but this means that factors influencing periodontal repair and regeneration. That article was published in 1982 in Journal of Periodontology. Main thing is how many periodontal tissue ligament was attached to the tooth surface. So intentionally induced periodontitis like this, and then we change this side, this, and the other side. So you can find this alveolar bone level is very normalized. This side's alveolar bone level is not lower, but this tooth surface, the root surface has a periodontal normal periodontium, which is normalized healing. This is normal. This is a hemiseptal bone defect. Hemiseptal bone defect. So periodontium is a very important factor for healing that alveolar bone level. So because of that, in this case, with third molar periodontium induced normalized alveolar bone level. So it's very important procedure. Okay. So contributing factors for successful positioning, transposition is the patient age, surgical skill, and orthodontic force. This is extrusion. Extrusion is very light force released. So the patient has a 3-unit bridge, but the upper impacted central incisor was curved like that. Yeah. So remove that old bridge and the crown reduction, gingivectomy and gingivoplasty, and like this. But the crown is a very small size. We made a normalized crown. But in this case, let me introduce that is extrusion force is very light. So this is you can find the extrusion is rapidly progress like that. This radiolucence is not inflammation. It's a normalized bone healing. That is 2 weeks, and 1 month later, and 2 months later, 3 months later, 6 months later, there's a perfectly repaired. And so extrusion is very simple and helpful for alveolar bone remodeling procedure. So if we met the block out upper lateral incisor, we extraction the premolar and the flare out the crown. We can use that bracket slot. In this case, gaining the space lateral incisor and your tube, microtube, was placed that like that. This side also microtube and three microtube placed that, and 012 NiTi wire, sectional wire engaged, and step by step, and finally we got. So your tube means and micro etching the tooth surface like this, green purple edgewise arch flux and the stops, and like this. Placement of the tubes and palatally displaced lateral incisor and edges in the teeth. 1, 2, 3, and engage there. Insert through the tubes. The wire is back. But nowadays, if you use that E-wire, do not tube, only wire, sectional wires like that, and attach the resin. You can easily get this block or lateral incisor procedure. So, step by step, the EVA tube system provides the transfer intrusion without vibrating. Sometimes you can block out, jumping out the upper lateral incisor. Many orthodontists and dentists use the bite block for jumping out. Yeah. But if you use this appliance or solar or E-wire, you can easily correct this assistance. So, block step by step intrusion, you can get the normalized lateral incisor position. And fine, okay. You can find that the upper lateral incisor. So like this. Over intrusion in this case, yeah. So you can find the over intrusion. Now is it translucent the plastic tube was placed in this case, but nowadays you can use the E-wire, sectional E-wire used at this 008 or 0010 E-wire, sectional E-wire, you can use that in this case right there. So the other case is older patient, you can use that. Okay, hello. So you can use that. Okay. So 6 months, 9 months, and 10 months. So 6 months and 9 months. 3 months later, this lateral incisor level was different. The intrusion was done. And 10 months later, the over intrusion. And then align that. You can easily correct that, the procedure. So you can imagine that not bracket, only wire. Wire is enough to correct that this malocclusion case. It's very simple. Do not use a bracket anymore. E-wire is enough for your anterior crowding relief. So how do you close the wide interdental space without loss of arch length? So edgewise appliance is 001 17 by 25 edgewise 18 slot. Rect wire engage that the translation is possible, but the friction is how to correct, how to so 016, if you place that wire, the bowing effect, that is a problem. If you full size rect wire, the friction is a problem. So anterior space closure is retraction and redistribution. Today's topic is retraction, redistribution without arch length decrease. So MD, major distal tooth movement, not arch length decrease. In this case, retraction is arch length decrease. Yeah. So central incisor without arch length decrease, like closing that central incisor and the lateral incisor, space gained, and implant prosthesis was done. Yeah. This power arm, bonded power arm, published a long time ago. If it is the full size rect wire and like this power arm, bonded power arm, and the elastic and the main arch wire and the bonded power arch. The bonded power arm and the lingual button and the 7025 SS wire like that. But nowadays, we didn't use any more lingual button, only directly place that 16 by 1725, 16, 25 SS wire like that. the microaction, and the power chain elastic alternatively engaged. The first step is placed at the bracket, the power chain, and 3 weeks or 6 weeks later, and then you place that upper bonded power engage. And the next 6 weeks later, we change the rule. So alternative chain exchange that the power chain first, and 6 weeks later engage, and 6 weeks later main arch. So alternative change that the elastic, you can pulse movement is bodily, can get bodily movement. So clinical evidence of a bonded power arm, you can. This patient was trauma, sorry, extraction of the upper central incisor. So we can move that upper lateral incisor and the translatory, and then canine align. So main wire and the transplantation, alternative engage, and finally we canine positioning the lateral incisor size. And lateral incisor the substitute to the central incision after prosthodontic treatment, before and after. You can find the radiopacity trans remodeling. There is a translation. So if you use that bonded power arm adjustably, you can get the root movement translation. So severe anterior diastema, this patient. So the space is so wide, the patient temporarily central incisor, temporary appliance. So it's very ugly. 3 upper central incisor. So we align the bracket and change the round wire and the open coil spring, and the rect wire. We change the rect wire and the bonded power arm. We can alternate to change the bonded power arm. Finally we get, and finally we implant. So step by step. Okay, finally we get the space closed successfully done, but the gingival condition is not healthy. So after that, we make the gingivectomy and gingivoplasty. So like this, and implant prosthesis. Okay. So this is a step-by-step space closure and implant prosthesis. Okay. The X-ray taking step by step. The distal area is alveolar bone remodeling mark. The skate is excellent. Implant is placed. Treatment times is 6 months. No root resorption. Area retention. It's good. But sometimes the alveolar, all elderly patients came to your clinic, the route to clinical crown is very long. The route to expose is severe there like this. In this case, black triangle. We can remove that black triangle, stripping in the crown size, stripping, and the root movement is weak. The center of resistance is downward to the root apex side. Center of resistance in the clinical crown is longer. The root is relatively shortened there. So we use that bonded power like this, stripping and the crown closing and bonded power. Root paralleling by BPA. The space is short, so we can like this diverge style. So, I in the crown. Before and after. Yeah. Only problem. The other side is sorry. Only power. Anterior spacing, and we can manage the problem successfully. So intrusion and extrusion. So tube appliance, don't use the tube, only E-wire. And this is a simple. And 4 months later, over intrusion you can find 3 months later. Sometimes not tube, only NiTi closed coil spring, super elastic coil spring. Yeah, you can get the over extruded apolateral incisor like this. So sometimes NiTi wire, sometimes NiTi coil spring, which is better than the others. I recommend NiTi closed coil spring is better than. But sometimes you can use the E-wire section. Okay, it's good. It's good. And so intrusion of palatally displaced maxillary lateral incisor using nickel titanium closed coil spring. Yeah. NiTi closed coil spring, super NiTi closed coil spring is first release amount is less than 50 grams. So it's very light first. Intrusion first is very light first. Yeah, like this. Okay. Sometimes with impacted canine, it's traction, extrusion, like this. It's very rapidly downward growth. So other terms, red patch, or if you can find. So there is rapidly extrusion, sign of substitution. So NiTi closed coil spring is recommended. So this side is a traction. Also, impacted metal canine was traction. So step by step. So finally, endodontics. Surgical repositioning. In this case is surgical repositioning. You didn't move that, so surgical approach and traction. Sometimes we over the deep overbite because of the lower incisor over erosion. So in the case, the posterior part, the rigid ankle part, and this is auxiliary, and intrusion by closed coil spring. 6 months later, the lower incisor bracket was covered by upper incisor level, but 6 months later, the bracket is fully exposed like this. So intrusion is a very light force applied. Don't apply the heavy force for intrusion. Intrusion is very light force released. So in this case also, intrusion like this. This is a light force. So this case is a long time ago. I used that bracket, but nowadays you can use that to substitute the E-wire and the closed coil spring, NiTi super NiTi closed coil spring. I don't recommend aligner. Aligner is a patient-dependent appliances. Nowadays, the aligner is issue about the microplastic and nanoplastic. So within soon, the issue is appeared in the orthodontic field. Yeah. So, any other questions?
Yes, there is one question, Professor. Please highlight a case with extraction of tooth, particularly canine, as these are the typical cases being raised. So, will that case can be done with E-wire?
Premolar extraction case is a possible the E-wire,
Yeah.
but that's okay. Yeah.
Oh, is it possible?
Yeah, possible. Yeah.
Okay.
But last time I showed that let me explain how to close that space closure. This is a bracket-based space closure mechanism. So last time I showed you that this case, the first step is alignment and leveling, and the bracket and the wire, and 16 by 16 NiTi, 16 by 22, lower 16 NiTi, 16 22 NiTi wire, and space closing, during the space closing, upper 1725 TMA accentuate curve, lower 1622 TMA reverse curve. This is this wire like this, low arches like this, and engage that, and space closing. Region stop, there is unmasked retraction first. So region stops and step by step, and lower space closing first, and 6 weeks later, the upper arch space closure. So alternative space closure is very important. So power change 8 weeks or 9 weeks, and the space closure step by step. Finally, we get that. That means if we use that E-wire only, the E-wire is only NiTi wire. So in this case, you can use the stainless steel or TMA curved wire. So from first to a second premolar, second molar to the canine area. Canine to canine is connected the lingual side, the velodrome wire. You can use that from posterior part and anterior segment. Posterior part and anterior segment, the rigid direct wire, and you can use that space closing, the power chain like this. This is a very possible procedure for the E-wire. It's very simple, yeah.
Okay, thank you, Professor. So, is there any other questions? If you have any other questions, kindly put in your Q&A box. So, meanwhile, I will be talking about D-Bridge, and yeah, let me share my screen. D-Bridge is an integrated platform. You can see who we are. So, it is basically a Korean-based medical and dental platform. So, here we are about to educate, and we are also launched a few communities, especially the dental community and the Korean aesthetic community. And we always do the discussions which is clinically proven. And talking next, that what we do, so it is basically that we deal with the evidence-based education and webinar, and the clinical exchange, or you can say clinical discussions, curated medical and dental solutions for daily practice, and evidence-based information regarding Korean skincare and facial aesthetics. What is our vision? So our vision is to democratize access to high quality medical education and technology. So, every doctor can deliver safer and more predictable care to their patients. Our philosophy is learn, apply, and share. And yes, we are excited to offer unique opportunities for our clinical partners. So active engagement with the D-Bridge can unlock, exclusive benefits, including sponsorship opportunities, KOL collaborations, and access to international speakers, as well as invitation as a guest speaker in some of the conferences or the webinar. And a special course discount will be also given, but subject to applicable terms and conditions. These are our social media, and you can explore our website, and also our we are available on all other social medias platforms where we regularly update and share contents time to time and regarding our upcoming events, so you can check it out. These are some of our key highlights. So we have attended few like conferences, and whether it is related to dental or related to the Korean aesthetics. So these are the few of the key highlights. Along with that, this is our team, and these are our partners. And talking
Correct.
about the deep breach products, so if you want to know more about our products, so you can access our website, and you can go to our SNS account, and you can get the list of the products that we have. So next to dental products, along with the E-Wire, we also have the Medbond bone grafts, and then we have also New Dent Pro Floss, which is said to be superior to Super Floss, that is from Oral-B. And if you want to contact us regarding anything, so this is our WhatsApp contact number and our email, so you can contact us. And yes, feedback matters a lot. So I would like to request to all the attendees to kindly scan this and kindly give your genuine feedback. And yes, certificate will be issued at the end, like maybe after completing the survey. And yes, this is all about debridge. Thank you so much. And sorry, actually, Medbone bone graft, it's not xenograft, it's a synthetic. So, and it consists of beta TCP. So, yes, nowadays, several research are going on regarding the beta TCP and HA, that is hydroxyapatite crystals. So, yes, you also need to explore this because it is one of the game changer in the field of implantology. So thank you, everyone. And now let's move to the Q&A thing.
Thank you.
And yeah, next we have other questions. Okay, what is the status of E-Wire? So yes, it will be available soon. Yeah. And thank you everyone for the webinar session. Now I would like to request Dr. Gurkirat to share his insightful feedback regarding this webinar session.
Okay.
So we are very thankful to Dr. Professor for the wonderful lecture. And the step-by-step means that he has taken all our participants through so that it is very clear as to what has to be done at which stage, which wire to be used, how much force, hooks to be placed at the right place to get a bodily movement rather than tipping. And I'm sure that it would have helped our future users as well as the people who are here to learn to get the knowledge that they desire to get the practice to the next level. I'm sure with the bridge coming in a big way, hopefully all their products will be certified and be available to us in India very soon. I'm thankful also to all the participants for spending their time to be here on the platform, and we hope that their support, continued support, would be really beneficial to all of us for education as well as in terms of sales and marketing. Thank you, Professor Chung.
Thank you. My pleasure. Yeah.
Thank you so much, guys, for joining us today. And we are truly overwhelmed by your enthusiastic participation. And yes, on behalf of Debridge, I extend my heartfelt gratitude to obviously Professor Chun, our esteemed speaker, our panelist, Dr. Gurkirat Singh, and our CEO, Mrs. An, and at last but not the least, to all the participants. And yes, we look forward to welcome you again on our next webinar session. So we will be telling you about our next webinar session very soon via email. And until then, keep spreading a smile and incorporate your motto, that is learn, apply, and share into your professional journey. Till then, thank you. Have a wonderful evening. Thank you, everyone, for joining us. Thanks once again.
Thank you.
Thank you.